Hey everyone, welcome to the UNC Neurosurgery Med Student Primer Series. I'm Marty Piazza. I'm one of the neurosurgery residents here, and we are going to be talking about upper cervical spine injuries today. We've divided this into three parts. Upper cervical spine injuries are quite complex, and we're not going to cover every bit of detail with these injuries, but my hope is that we can give you a basic foundation and context for some of the commonly seen injuries that you may come across in your rotations. All right, so first we got to talk about cervical ligamentous anatomy. This can be quite confusing, but it's really important to understand these ligaments when you're discussing the injuries in this region because they play a major role in providing stability to the craniocervical junction. And to make matters worse, some of the ligaments that are found throughout the spine get renamed in this region, so we're going to talk about those as well. So first, the anterior longitudinal ligament, or the ALL. It's the one that's anterior to the vertebral bodies. As you approach C1, it's going to be renamed the anterior Atlanto-Occipital membrane. The PLL, or the posterior longitudinal ligament, that's the one that's dorsal to the vertebral bodies. That's going to become the tectorial membrane as it approaches C2, and then it'll eventually connect to the basion or the clivus. Posterior to the cord, we've got the ligamentum flavum. That doesn't change its name. In between the spinous processes are the interspinous ligaments. In between C1 and the occiput, this is called the posterior Atlanto-Occipital membrane. Now for the high cervical specific ligaments. The transverse ligament is probably the most important, as it's going to come up in multiple injury types. It connects the internal side of the lateral masses of C1 and holds the odontoid process of C2 anteriorly, preventing it from pushing against the spinal cord. It's in between the dens and the tectorial membrane. And the dens and odontoid process can kind of be used interchangeably. The transverse ligament is connected to the ascending band attaching to the clivus and the descending band attaching to the dorsal C2 body. Together with the transverse ligament, the ascending and descending band are called the cruciate ligament. The alar ligaments attach the odontoid process of C2 to the occipital condyles, and the apical odontoid ligament attaches the tip of the odontoid process to the basion. So now that we've gotten some of that anatomy out of the way, let's talk about some patient demographics and epidemiology. Cervical injuries are the most common spinal injuries. Note here in these figures that Atlanto-Occipital Dislocation and bilateral jump facets have almost 100% chance of neurologic deficit, but atlas and axis fractures have a much lower rate. This is probably due to the widened canal at these levels. That doesn't mean that these patients are necessarily stable, so it's important to really understand the injury that the patient has and treat them appropriately, as they can develop neurologic deficits if not treated appropriately. Most common mechanisms for these are MVCs, falls, and sports-related injuries. Young adult males are the most commonly injured, and then the upper cervical spine injuries from C1 to 4 are more common than others. So first, let's talk about Atlanto-Occipital Dislocation. This is a purely ligamentous injury, and as you can see on the sagittal CT scan on the left, the basion and tip of the dens are widened, and this indicates that there's damage to the apical ligament. And on the right, this MRI sagittal image, you can see that there's signal change in between the occipital condyles of C1, suggesting that there's injury there as well. And clinical presentation for these patients can vary widely, from no neurologic deficit to significant motor deficits, or even an exam consistent with brain death due to stretching of the cranial nerves and the brainstem even. When the patient presents with no neurologic exam, sometimes we refer to this as internal decapitation. So this is a really serious injury, and even if they present with no neurologic deficits, they can rapidly decline if they're not treated appropriately and diagnosed quickly. There are three types of AOD. Type 1, there's anterior displacement of the skull on the cervical spine. Type 2, there's purely vertical displacement. And type 3, there's posterior displacement of the skull and the spine. The two major measurements we use to diagnose AOD are the Bayesian-Dens interval, or BDI, and BAI, or the Bayesian-Axial interval. The BAI is measured from the tip of the Bayesian to the rostral extension of the posterior axial line, which is the line from the posterior margin of the body of C2. And that's better for anterior posterior displaced AODs. And that's typically determined by X-ray. In adults, it's between -4 to 12 millimeters, and in peds, it should be less than 12 millimeters. And BDI, or the Bayesian-Dens interval, and that's the measure from the Bayesian to the tip of the dens, and that's the best measurement for the distracted type, the type 2 AOD. On X-ray, it's going to be less than 12 millimeters in adults, in normal adults, and on CT, it should be less than 8 millimeters in adults and less than 10.5 millimeters in pediatric patients. Of note, pediatric patients in general have increased ligamentous laxity, and so in general, their normal ranges are a little bit larger than adults. So other measurements you need to know for these ligamentous injuries are the power ratio. The powers ratio measures the relationship of the foramen magnum to the atlas, and it's a ratio of two lines. The first line, which you can see is the AB line in the upper image here, is the line from the Bayesian to the posterior atlas, and the CD line, which is a line from the episthion to the anterior arch of the atlas. This ratio should be less than 1 centimeter on X-ray and less than 0.9 centimeters on CT. The Atlanto-Dens interval is the distance between the anterior arch of C1 to the anterior cortex of the dens and the mid-sagittal plane. On X-rays, it should be less than 3 millimeters in adults and less than 5 millimeters in peds. And on CT, it should be less than 2 millimeters in adults. If there is an abnormality in the ADI, this suggests strongly that there is a transverse ligamentous injury. So typically, if some of the measurements are normal, you can trial external orthosis or a halo brace for 8 to 12 weeks in these types of injuries. The halo brace is used exclusively for high cervical injuries and cannot be used for lower cervical injuries because it fixes the head to the thorax but doesn't stabilize anything in between. So these patients can sometimes have lower cervical snaking or mobility in their lower cervical spine when they're in a halo brace. If there is more than one abnormal measurement, the patient should undergo internal fixation in the form of an O to C fusion or occipital to cervical fusion. This is going to result in significant reduction in mobility and ability to turn the patient's head, which is obviously the point of the surgery because they're unstable. And the patient needs to be alerted to this before surgery because it can have a significant quality of life implication. And should not be a surprise to the patient or their family post-operatively. Okay, so the next one we're going to talk about is Atlanto-Occipital Instability. So the Atlanto-Axial joint provides 50% of rotation in the cervical spine. It requires multiple ligaments to maintain stability, though, specifically the transverse ligament, the apical ligament, and the alar ligaments. The Atlanto-Axial Instability is thus strongly associated with ligamentous laxity in this region. So patients with Down syndrome, RA, or osteodyntitium, Morquio syndrome, they're all examples of conditions that are associated with increased laxity of the ligaments, but can also be associated with a variety of injuries, including fractures of C1 and C2. As a result, AA instability can be thought of as a group of injury types in this region as opposed to just one specific injury. Again, the Atlanto-Dens interval is important. Greater than 3.5 millimeters is considered unstable in adults, and greater than 5 millimeters is unstable in children. You can also get flexion extension X-rays in these patients, and if there's a change in that interval, that's an indication that there is ligamentous injury. And the treatment of AAI is going to depend on the underlying etiology, so that's an important point. So the function of the C1-2 complex, as I mentioned before, is to allow for a significant amount of head rotation. Rotary subluxation refers to a facet dislocation of C1 on C2, resulting in forced turning of the head in one direction that the patient can't overcome. The mechanism is thought to be due to ligamentous laxity again in children, but it can also be associated with Downs, RA, congenital anomalies, and previous infections as well. And the transverse ligament may or may not be intact. So there are several types here. The first type, type 1, is a unilateral dislocation with intact transverse ligament, and that's the most benign. Type 2, there's a unilateral facet dislocation with an injured transverse ligament. There's 3 to 5 millimeters of anterior displacement of C1 on C2. Type 3, there's bilateral anterior facet displacement, greater than 5 millimeters, and both lateral masses are displaced. There's a higher risk of neurologic injury in this type. And then type 4, there's a posterior displacement of the atlas. This is oftentimes concomitant with a Dens fracture or a hypoplastic Dens. This is rare, but there's a high risk of neurologic involvement here. For rotary subluxation, the patients oftentimes have what we call a cock-robin posture with ipsilateral rotation of the head and contralateral tilt of the head to the affected lateral mass. The chin's going to rotate to the opposite side of the subluxation due to SCM spasm, whereas in torticollis, which can sometimes be confused, the SCM spasm is going to occur on the opposite side of the chin, meaning that the left spasm will rotate the head to the right and the chin will be on the right. Dynamic CT is the gold standard imaging modality when you're trying to determine if a patient has true atlantoaxial rotary subluxation. So you have to do a neutral CT, a left-facing CT, and a right-facing CT. And the patient, if the patient is unable to reduce past 45 degrees, then they have AARF. Treatment for these patients without a compressive lesion is going to be stepwise. So we start out with a soft collar, NSAIDs, and some muscle relaxants and exercise. If that doesn't work, then we'll put them in a halo, reduce them under anesthesia, and put them in a halo. And if that doesn't work, then the patient is committed to C1-2 fusion. Right, here are our references. And if you'd like more information on future educational content, please follow us on Twitter at UNC Neurosurgery. Otherwise, stay tuned for part 2.